Mental Health Committee meeting for Tuesday, August 17th, 2021. If you could please join me in a moment of silence for all of our loved ones and members of our communities that have passed, and the Pledge of Allegiance. Doreen, can we do a roll call?
Absolutely. Amo, Anagnostakis. Lujan, Sutherland, Tortel, Tui.
Here.
O'Donnell, 4 present, 3 absent.
Okay, I see number 1 on the agenda, we have Commissioner Darcy Miller of Social Services and Mental Health. And Commissioner, if you could give us the monthly update, please.
Good afternoon. So just to give you a couple of things that we're working on, in our last committee meeting, we just talked about the increase in mental health and/or substance use issues in our county relative to COVID experience. So in response to that, we're trying to put together some planning that will increase people's access to care. Most importantly, 311, 311, 311. Call 24/7 if you have a need. But recently we were approached by Assemblywoman Gunther's office asking if we could use some assistance with crisis intervention training with police. So I just submitted on Friday to her office an expanded plan that would allow us to increase our collaborative mobile crisis collaborative response with police departments, focusing on her jurisdictional areas and going out west towards Port Jervis. So I'm hoping that that plan will be approved. It would give us approximately $1 million over 2 years. It would be one-time funding, but would allow us to do an intensity of service that then could bear out the importance of funding that kind of intensity of programming to increase safety, and not only for our citizens, but also for our police officers who are often first to the scene when we have a mental health crisis in our community. So that's a positive news. We were awarded $300,000 from the Partnership to Support Aging in Place and Communities for those who are severely impacted by COVID, and that effort was led by Lacey Trimble, who is the Deputy Commissioner for the Department of Mental Health, and that brings together the Department of Mental Health, Social Services, and Aging, along with a number of our community providers that will allow us to go into the homes of our aging population, do evaluation, connect them to providing therapy right in their home. So we're pleased to have that opportunity to have that funding continued for another 5 years, and that is $300,000 for each of those 5 years. Next year we'll be in with a legislative request to receive those funds, so we'll look forward to that. I was asked the question about remote versus in person. We continue to have quite a bit of remote work happening in the community, some of that very successfully. But we also have increased numbers of face-to-face sessions, and particularly with children and young adults. As you can imagine, it's easier for an adult to find privacy in their home than it is for a young person. So we want to be sure that they have the opportunity to have their therapy in private as appropriate. Just the last meeting we had, there was some discussion. I did follow up and send a report out regarding the overdose numbers here in the county. And I do have some updated numbers, but Legislator Sutherland will be hosting the opioid subcommittee on Thursday, and you'll get the full PowerPoint at that meeting if you attend, or it can be sent to you. Numbers that we do have confirmed by the medical examiner's office with some April and May not fully reported for January through May of 2021 was 50. When you look at our OD map, which is another source of us getting unverified numbers of fatalities, we are pleased to say that we see a reduction from January through August. We're showing 77 fatalities, where in that same time period in 2020, we had 121 fatalities. So if these numbers bear out, once the medical examiner's office is able to fully assess and come out with accurate figures, we will be seeing a reduction in those numbers across the county, and we're pleased to be able to report that at this point.
Thanks, Commissioner. And is there anything that you can kind of glean out of this as far as that decrease? It's a great decrease. I know we're coming out of the pandemic, but what are your thoughts on that?
We think that's part of it. We're coming out of the pandemic, and people who were at high risk of relapse and unfortunately lost their lives due to that. Last year was the beginning of the pandemic when people weren't able to do face-to-face, and those relationships, I think, got lost in the mix. So I think that's had an impact. Having some face-to-face going back is really positive. Also, I would want to look at the numbers closer regarding the substance in the community, because fentanyl is what the substance that most often connected to fatal overdoses. And the last time I looked, it looked like there was less fentanyl involved in the overdoses. So we'd want to have all of that data verified. If that is in fact true, then that has to do with some of the fentanyl being off the streets. Maybe it's because people are using fentanyl strips, so they're able to see that what they're ingesting has fentanyl in it before they use, which would be positive. Also, we're showing a pretty significant increase in naloxone, so that's Narcan. We showed from January through August of 2020, 126 administrations of Narcan, and in the same time frame this year, we saw 166 administrations. Also, emergency rooms now, if somebody comes in with an overdose, they're having them leave with, so a non-fatal overdose, they're leaving with a Narcan kit from the emergency room.
And that's new? That hasn't been in the
Correct,
past?
yes. We have overdose response teams that are working together with law enforcement, ODMAP, and our crisis continuum peer supports. That if someone comes with a non-fatal overdose, we're reaching out to them and connecting with them, trying to engage them into treatment, or at least begin a relationship so they can move in that direction. So we hope that a number of these things are what's making a difference in the reduction of numbers.
Well, I think that giving them the Narcan kit on leaving is a great thing. I mean, it really brings that awareness home that they were near death. They came back. And I think that just looking at that would be a very strong reminder, and that hopefully that's enough to put them over the top to want to get help, you know.
Yes, agreed, because our non-fatal overdose numbers are up. So same time period, 346 in 2020, 409 in 2021.
Say that again. What was that?
Our non-fatal overdoses, again, by ODMAP numbers, are up from 346 last year to 409 this year.
Okay.
So Narcan is working.
It's helping.
Is helping, correct, yes.
Fellow legislators, are there any other questions or follow-up for the commissioner? Not seeing any. Commissioner, I want to, Legislator Tortel? Sure.
We touched on that. Have we been tracking the calls into 201 regarding, I've seen billboards for COVID, people reaching out for mental health crisis and mental health issues related to COVID. Also, I've heard some talk about suicide rates are increasing. I want to know if you had any information on that.
We just had the conversation this morning. Unfortunately, the suicide numbers that we get at the Department of Mental Health are in the rearview mirror. So we're looking when the Department of Health, New York State Department of Health issues those numbers, they're not current. Commissioner Irina Galman might have a little more updated through the medical examiner's office than what I am able to see, but I will tell you that our suicide prevention task force is very active. Last year worked on a campaign specifically targeting the highest rate population, which is white males over 55. And we continued it with that campaign going forward. Our 311 ads going out. We have the National Suicide Prevention Foundation comes in and does trainings monthly here in this county. And literally we have as many as 95 to 100 people attend those trainings each month. So having more and more gatekeepers, more and more knowledgeable people out there, when you hear something, say something, recognize the signs, symptoms, county executive was just saying this morning, and I've already read some articles today, that what's happened in Afghanistan may have triggered for some veterans, and particularly those who were involved in Vietnam. So you're paying special attention to that population in our community who's at risk of suicide. So all we can do is, prevent, educate, really support people who are struggling.
Thank you, Legislator. Are there any other questions this time? Okay, Commissioner, I'd like to thank you very much for joining us today.
Thank you very much. Have a good afternoon.
Take care. All right, number 2 on our agenda, we have Dr. Gelman, Commissioner of Health, Deputy Commissioner Erickson. If you could come up and join us, and thank you for being here.
Thank you very much.
Item 2A, we have a request to accept and appropriate funds from the New York State Department of Health for the extension of the contract for the lead poisoning prevention program grant for the period of 10/1/2020 through 9/30/2021 in the amount of $196,808. Legislative request number 140. Can I have a motion, please? Tortel and Sutherland. Commissioner, could you?
Yes, thank you very much.
bit.
So our lead poisoning prevention program, as is outlined, we have attached a budget for the utilization of the $196,808. That includes permanent base salaries, fringe benefits, employee retirement systems, chargebacks, office supplies, and various other items that are outlined. The program, it's quite an extensive program for lead poisoning prevention, as you are well aware. And we are currently implementing that program and are requesting that these funds be approved.
Any questions? Seeing none, I'll call to question. All in favor, say aye. 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 Any opposed? Passed unanimously. We have number 2B. It's a request to accept and appropriate funds from the New York State Department of Health for the ELC Reopening Schools Grant for the period of 6/1/2021 through 7/31/2022 to be used for school districts in Orange County to establish COVID-19 screening testing programs to support and maintain in-person learning in the amount of $10,566,420. It's legislative request number 147. Can I have a motion, please? Tortel, Sutherland? Hey, Doctor.
Thank you very much. These are new grant funding that is available, that is being made available to all counties. The appropriation is based on population size. The amount of $10,566,420 has been made available to Orange County to ensure that there are programs, including screening testing, to support and maintain in-person learning. Now, these are pass-through funds from the federal government that were passed on to the State Department of Health, and as a result, they are passing on and allocating those funds to each county, as I mentioned, based on population size. We have attached a very generalized budget. A majority of the counties, in speaking with their BOCES, have reallocated the funds to BOCES to be utilized as needed. Thankfully, the approved uses for the funding have been expanded to include air safety, health education for COVID-19, among other uses. So we are keeping open discussions with BOCES and have allocated a very small amount of the funds to include certain necessities for the health department, whether they're technological needs or potentially a mobile clinic unit where we're able to support this particular service.
And you'd be taking the mobile unit around to the schools?
Potentially, if that's something that's needed down the line, but we would like to have the opportunity to do that, and whether that clinical mobile unit is used strictly for testing or screening purposes, vaccination purposes, and health education. It's quite versatile.
Okay, when you mention screening and testing, are you saying that in two different terms, or?
Yes, so there are screening testing such as surveillance testing, and then there are actual diagnostic testing. We are able to utilize both, but fairly often schools utilize their own contractors that they're either comfortable with or that are local medical providers where there's continuity of care that's preserved with notification of the patient, possible treatment, and so on and so forth.
So screening would be more looking at symptoms and things like that rather than an actual test?
Screening typically within the context of COVID-19 would be surveillance testing, which would include pooled sputum testing just to see if there is a presence of infection within that organization or population. And then upon any positive results from that collective use of the testing, then the subsequent actual diagnostic testing will be utilized, individualized diagnostic testing.
Thank you. Any other questions from fellow legislators? Majority Leader Benelli?
Thank you, Mr. Chairman. Excuse me. Hi, Dr. Gilman.
Hi, good afternoon.
I'm trying to figure out the chain of command here. With this particular funding, we're receiving it, and then we're distributing it out to BOCES, not individual school districts.
Yes, potentially, hopefully.
And then who is responsible to make sure that we adhere to the guidelines that the funding is supposed to be applicable to?
Yes, so that's part of the contract that would be set in place with whether that's BOCES or other contractors or vendors, clearly staying within the parameters of the grant allocated funding, because this is not the only stream of ELC funds. We have received multiple or are set to receive multiple streams of ELC funds. This is just set aside specifically for screening and testing within the schools.
Okay, and we're responsible to prepare and execute those contracts?
Yes.
Okay, all right, thank you.
Legislator Sutherland?
Thank you, Chairman. When you talk of the pool testing,
Yes.
is that would that be performed then in each school throughout the county? Is that, and whose discretion is that at? Like how that happens?
So typically it's up to the school districts what type of screening or testing parameters they would utilize. As I've mentioned in the previous sessions, we are set to deploy the wastewater testing with notification to some areas that are seeing higher rates of transmission or higher burden of virus within the effluent, within the wastewater. Following that notification, obviously up to the purview of the medical director of that school district, they would then decide what are the adequate parameters. It's not a one-size-fits-all. Some school districts are very vast, very large, so they may have other vendors, or maybe they would resort to local providers just for ease of use, but that's something that is available to them. As a primary means of screening, we would have that wastewater testing for that primary means of surveillance and notification. Secondary surveillance would include something along the lines of pool saliva testing, which has been utilized by SUNY broadly in the past, just to see if there is a presence of positive testing results within that collected sample. It's just fiscally more responsible to approach it that way rather than individualized one-on-one testing. And then once we are actually seeing a confirmation of broader spread within that particular population that we're testing, then we would have individualized diagnostic testing such as PCR.
Okay, and then, so the medical director of each school district would be making that decision with school boards, with superintendents?
Collectively, yes.
All right, thank you.
You're very welcome.
Any other questions, please? Not seeing any. I'd like to call a question. All in favor, say aye. Aye. All opposed, say nay. Unanimous, passed. Item C, discussion on mask mandate.
So I'm not sure what the context of this particular discussion is. I believe it's a bit premature as we await sort of the fallout from Albany to see where the New York State Department of Health is with regards to their guidance, whether that's on a mandatory basis or not. But in general, as far as where we are, and I think this is a good segue into the overarching report that we typically submit from our department, we are seeing a high rate of transmission of COVID-19 within Orange County. We have issued a public health alert. The Orange County Department of Health has issued a public health alert on August 12th with regards to mask recommendations in Orange County, as our community is experiencing a rise in cases, in large due to the Delta variant. We are seeing an increase, and more so, the CDC has designated Orange County, and that was classified based on our rate of transmission as having high transmission within the community. That has been increased from a very recent, as of 2 weeks ago, substantial rate of transmission, and we were at moderate rate of transmission just 2 months ago. So based on that, it would be very prudent for all individuals, as has been continuously recommended by the CDC, that remain unvaccinated to continue to wear masks when not in their own homes. And clearly, environments that are congregate in nature or that contain susceptible or vulnerable populations such as seniors, immunocompromised individuals, hospitals, schools, nursing homes, and other facilities, it would be very prudent for largely unvaccinated populations in congregate settings to remain masked. That's a very baseline protected population health measure.
Thank you. I have one question with the regard to, I think it was about 10 days ago, the Albany put out and said that it would be, after giving guidance for a year and a half, they were going to give it to, and so many meetings and so many times we've talked, and, we had to say, well, it's not, we're going by the federal guidelines, CDC guidelines, and the mandates from Albany. Then it seemed that they just reversed course, and then they said, no, well, it's going to be the county health departments and the school districts. And then I think it was 3 or 4 days later, the head of the education department said, no, we're going to be issuing some guidance. And can you give us some guidance about it as to where we stand today?
Absolutely. So unfortunately, due to the upheaval that everyone is very well aware of in Albany on the political landscape, the New York State Department of Health has not released the draft of the guidance that they have drafted as of yet. And that's what we saw result in that New York State Department of Education letter. The commissioner of the New York State Department of Education has written that infamous letter to Dr. Zucker, who is the commissioner of health for the New York State Department of Health, really trying to have the New York State Department of Health actually release the guidance that they have drafted. The New York State Department of Education since has released guidance. It did not have any mandatory language contained in that guidance document, unfortunately, and it still remains in limbo until the New York State Department of Health releases that language and that guidance document that they have drafted. So for the time being, it does reside with the local health department, the school boards, and the respective medical directors of the school districts. Clearly, there is absolutely no medical or clinical parameter for removing a protective measure from a population that is largely unvaccinated, that remains in a congregate setting for a prolonged period of time during a continued pandemic, especially in the presence of the Delta variant. That guidance from the CDC still stands for all unvaccinated individuals to remain masked, specifically so for school settings. All of the pediatricians in the United States of America came out with collected guidance that is in line with the CDC guidance, recommending masks in schools to disrupt the continued transmission of COVID-19 within a school setting, which is a congregate setting and contains largely unvaccinated populations. Populations under the age of 12 by default are currently not approved to receive vaccination. And according to our statistics, about 50.9% of the total population of Orange County is currently vaccinated. If we are to extrapolate that number and apply that to the staff, to the teachers and volunteers in the schools, you have approximately 50% or slightly more of the staff and teachers and volunteers of the school vaccinated. So overall, you have a predominantly unvaccinated population. When we are looking at guidance, whether that language is mandatory or suggested, Again, all pediatricians and medical professionals agree. I've spoken with a number of the medical directors for the schools, and there is a consensus in the medical community as far as the necessity at baseline for masking while in schools for individuals that are predominantly unvaccinated to stop rampant propagation of disease. Again, when we're looking at these measures, these are not individual measures. These are measures applied to the population as a whole, because this virus, because of its pandemic status, is spreading throughout the entirety of the whole population.
Okay, thank you. And are you in contact with the superintendents of the schools in Orange County?
Most certainly on a daily basis, yes.
Figured that. And when do you, school opens in, I think, 2 weeks or so.
So there have been ample discussion, again, to eliminate redundancy, unnecessary redundancy. We are hopeful, and we are hearing that there will be guidance issued from the New York State Department of Health. As you are aware, we were the first county. I have issued commissioner orders. Originally, we were the first county to issue commissioner orders mandating masks in schools early on. At that point, we had a much lower rate of transmission that we currently are seeing right now. Throughout the entirety of the pandemic, we have not seen numbers as high in our population 18 and under. We have a number of pediatric cases in the ICU currently, as you and I speak right now. Unfortunately, I am personally aware of a number of cases that are under the age of 10 that are hospitalized in the ICU currently due to COVID, not as COVID concurrently with other infections or conditions, but predominantly due to COVID infection. So it remains to be seen where the New York State Department of Health is, again, to eliminate redundancy, not to unnecessarily issue a set of orders, then rescind them, and then follow New York State Department of Health guidance. These are very interesting times, and unfortunately, guidance changes by the hour.
And over the last year and a half, children seem to be less vulnerable. So now with the children under 12, under 10, are they more vulnerable now because are they getting the Delta variant? Are they?
So we're seeing
not-
Delta variant circulate. I would say it's a misnomer that children are less affected. From the beginning of the pandemic, we have seen 6,261 cases in individuals 17 and under in Orange County alone. And that's out of an N value of 49,515 at the time, because this is taken as of August 11th.
That number one more time?
Absolutely. So for individuals under the age of 17 in Orange County, we have had, and keep in mind, these are lab-confirmed cases. Pediatric cases typically are less likely to test. They're more likely to present as asymptomatic or mildly symptomatic, and very much less likely to test in adults. But out of the PCR-confirmed tests that we have for all individuals in Orange County, the cohort of 17 and under attributed for 6,261 cases in Orange County out of a total N value of 49,515 confirmed cases. So very adept, they contract and transmit disease very readily. In terms of complications, and this is something I briefly mentioned at our last meeting, seldom if ever do we mention the complications and the long-term complications. Typically in our discussions, we tend to address acute infection, rates of hospitalization, and rates of mortality that is involved with COVID-19 infection. We are seeing quite a large number, and again, this is locally, this is statewide and nationwide, of long-term repercussions of COVID-19 in pediatric and adult populations, and those include cardiovascular issues, neurological issues. Those include not just respiratory alone, but we are seeing other issues, and they're more systemic, and they are chronic and long-term rather than acute.
Yeah, I've seen that too in my personal life with friends, and they're having the long-term effects. Are there any other questions from the legislators? Legislator Sutherland.
If I may, thank you, Chairman. I respect everything that you're saying. I think by saying, though, that all medical professionals and all pediatricians, because I actually do know, too, who do not agree that children should be masked the entire time, during the school day. One child sick from COVID, the same way one adult sick from COVID is one too many. And obviously, we see these numbers. But I think that I will say that for every one email that I get from a parent throughout the county that wants the children to go back and wear masks, I am truly getting, 24 that don't want that. So I don't envy anybody's position in this, but 6,261 children under the age of 17 is too many. That being said, in the big picture, I mean, how many children do we have in Orange County?
So about a quarter of our population is pediatric, and we're seeing about a quarter of the current cases being pediatric as well. And just as a point of reference, the American Academy of Pediatrics came out with recommendations, and that's really a consensus of all pediatricians in the nation, where they do tend to agree, and masking along with other protective measures, but masking nonetheless. In terms of pediatricians that disagree, all medical professionals are duly licensed to practice medicine in New York State. They are more than welcome to utilize that license if they feel strongly and they're in strong opposition to. There are a number of medical or mental health conditions that would preclude an individual, whether adult or pediatric, from wearing a mask for the duration of the day. A lot of the parents that call, whether my office or other offices, are advised to speak with their pediatrician and medical provider and provide a medical note attesting to the fact that there is a medical or mental health condition precluding an individual from wearing a mask, and they are exempt just like any other medical exemption. So I completely respect other opinions, but there is an actual consensus document from the American Academy of Pediatrics attesting to the efficacy and the necessity of use for masking. Because when we are discussing masking, unfortunately, I don't have the luxury of reviewing those cases, and perhaps I would agree with my colleagues where those individuals may not have to wear a mask, again, due to comorbidities, medical conditions, mental health issues that would preclude that individual from wearing a mask. They are more than welcome to write a note. They do not need to specify the condition, obviously due to HIPAA regulations. They could just simply state that there is a mental health or medical condition. They are putting their own license on their line. They are undersigning and attesting to the fact that they are removing a protective measure from a population that is largely unvaccinated during a pandemic in lieu of a personal situation, individualized situation that warrants not wearing a mask in that scenario. Because when we are discussing this, this is not a one-on-one. Anytime you do have a doctor, whether that's a pediatrician or a family practitioner, they absolutely know their own patient best, and they are welcome to utilize their license to write that medical note, write that medical exemption, put their license on the line, attesting to the fact that jeopardizing the health and wellness of everyone else in that congregate setting is warranted due to the fact that their patient is exhibiting a medical or health condition.
So since you're, obviously talking to the school districts and the superintendents, weekly, if not daily at this point, are you seeing more school districts opting or leaning toward, shall I say, mask mandates versus not having a mask mandate?
That's a very interesting question. As far as the survey and there were official surveys and unofficial surveys of just parents largely and the county as a whole. And when I say official, unofficial, so there's empirical and anecdotal evidence. There were surveys maybe that were conducted by sources that are unofficial, where they're just random surveys with not really tested adequate tools that were utilized. And then there were actual quantifiable qualitative analysis tools that were utilized by institutions, so educational institutions. When the county population was surveyed, interestingly enough, and this may be counterintuitive, we have about 56 to 60% of our population that do support protective population health measures that include masking and include vaccination. We have about 10% that are really truly on the cusp. They're sort of on the fence and they are not leaning one way or the other. They're just torn. And then out of the remainder of the 30%, you have about a 10% that are staunch. No matter what evidence or level of evidence is presented, they are just absolutely against any population protective health measures. And then out of that, again, remaining 30%, with the 10 being just staunch, no protective measures for the population health as a whole, you have about 20% that do not want to see those protective measures in place, sheerly due to just pandemic fatigue and frustration and things that we're all experiencing as a result of this ongoing pandemic. So I found that to be a very interesting statistic, and that has been fairly consistent numbers. So despite the fact that you do have a very vocal minority that does oppose a lot of these protective measures, what is not included in the discussion is the perspective. I think very often a perspective is missing from the discussion, and when we are discussing this, all medical directors of the school districts absolutely, and this is an absolute value, support masking in schools as a population health protective measure, again, during a pandemic for largely unvaccinated populations. Because at that point, their perspective includes the entirety of the cohort that they are trying to protect from disease transmission. So when we're looking at this globally as a population health measure, again, an individual has a right to be diseased, an individual has a right for their child to be diseased. Once you are passing that disease on to another individual in a congregate setting, that's when population health steps in and looks at that propagation of disease as a whole within the population. This is no longer a doctor-patient relationship where we're examining what's best for you based on your underlying medical conditions, comorbidities, or potential other aspects. We are now looking at propagation of disease as a whole, and of course, anything has a risk-benefit analysis. So when we're discussing that, it's not a simple answer. I wish I could say all school districts are for it, or all school districts are against it, smaller ones are for or against. Without bringing any other aspect into the discussion, strictly clinically and medically speaking, I have not come across any number of doctors actually that are willing, again, to place their license on the line and provide medical and clinical justification from removing a protective public health measure from a predominantly unvaccinated population during a pandemic in a congregate setting where they're convening for hours at a time, where they're undersigning with their medical license for it. So medical directors are absolutely all for it, yes, but then you have pushback.
In the school districts?
Yes, absolutely.
In Orange
unequivocally.
County?
Yes,
Okay, thank you.
thank you.
Thank you, Commissioner. I know that you and your department, as well as all the departments in the county, have been doing extraordinary work during extraordinary times. The one part you had said that under 17 represents what percentage of the 49,651 cases?
So no, the under 18 presents 25% of the total population of our county.
Right.
So pediatric from 385,000 residents that we have, about a quarter, give or take 2%.
Right, I got that down further on the report, but
And for I did not provide a percentage, unfortunately, it's 6,261 out of 49,515. That was the total sample size as of August 11th. We're way past 50,000 at this point as far as confirmed cases from the beginning of the pandemic.
and then at our last legislative session, we had a smattering of residents who were here speaking out against mask mandates. Like you said, that 30%, I believe you quoted. I get different, it depends on what website you look on. And I've done a lot of research on this about the health effects of constantly wearing a mask for extended period of times throughout the day, whether it be somebody who is, 3 or 30 or 60. What have you learned in your process with this, and can you enlighten us a little bit more on that? Because you have these people who are quoting this website and that website, but then if you go to another website by another health department, and then there's the size of the molecule of the virus versus the type of mask you're using, and if you could give us a little bit of
Absolutely.
on that.
So in terms of just evidence-based articles alone, there are a number of research, and when I say research articles, with an actual high degree of evidence-based, so these are legitimate evidence-based articles, not anecdotal data, not sort of editorials or opinion issued pieces. I can most certainly forward those. There are NCBI studies, there are JAMA published studies. These are retrospective case analyses, absolutely attesting to the efficacy and the necessity for masks. Again, as a baseline, especially in certain settings, such as congregate settings, for individuals that are largely unvaccinated. In terms of masks alone, please include in your evaluation of it the fact that all medical professionals wear masks on a daily basis. I have a surgical, I've practiced surgery in the past. Having a surgical field of practice in my residency program, I have worn masks for a protracted period of time. We're talking about surgeries that lasted 4, 5, 6, at times 8 hours at a time. In my second year of residency, I was 8 months pregnant while operating and having a full caseload, and I continued to wear a mask in the OR for the purposes of curtailing disease transmission. So this is most certainly not anything that is novel. There are constantly new articles and publications on the efficacy, safety, and proper use of masks. But I will say that with a caveat. Clearly, when you are setting up any protective measure for failure, whether that's pharmacological intervention, whether that's medical intervention, or anything else for that matter, if you have individuals not adhering to proper use, clearly that protective measure is not going to work. If you have individuals wearing masks improperly, if you have individuals not washing those masks. I've seen some residents have a mask for the duration of the pandemic. It was the same mask, and it was just used strictly to get into a store, let's say, or to ensure that they're granted access somewhere. Clearly, that's not a protective measure. That's no longer a protective measure because without having proper cleaning, proper usage, proper storage of that mask, it's not going to be as effective. So I think that goes without saying, and I think that's really applicable to really anything. If we were to use our undergarments improperly and wear them for a duration of 1.5 years, I would imagine that would pose issues, especially infection control issues as well. Similarly with the mask, it just requires proper use and intended use. Use for actual containment of your own bodily fluids, so you're not passing on droplets, and that's the predominant means of spread. I know we've heard aerosolized, I know airborne. It's not really airborne, it's more aerosolized than airborne. It is droplet transmission, so all we're asking is that mask properly contains the droplets from one individual, so it's not spread onto the other individual. That's really it in a nutshell.
So you had touched on the unvaccinated, and you're saying how the mask protects people around. I'm wearing my mask, so it's protecting you.
As well as yourself, right.
Okay, so yeah, could you delve into that a little bit on how much it protects us? And then we had talked about this, I believe, once before about the vaccinated people wearing masks and how it increased the percentage of effectiveness in protecting you from contracting COVID, especially unvaccinated people getting asymptomatic COVID and transmitting it to somebody else.
And none of the discussions are in absolutes. I think it's very important to note that these are not absolute values where I know vaccine breakthrough is fairly often mentioned. Vaccine breakthrough in clinical trials for mRNA vaccines has been shown to be at 5% of the total population that was examined at the time. And this includes hundreds of thousands of individuals that were originally vaccinated, and they're continuously tracked. In the field where we're seeing this right now, we're seeing a much lower rate of vaccine breakthrough, so statewide reported. And again, this will change with time, not because of vaccine efficacy or changes to vaccines. Unfortunately, we did not reach that 80% threshold of immunization. The reason that 80% threshold was really necessary is to eradicate disease and stop propagation. If we were ever hopeful to eradicate this disease and stop propagation, we really needed to reach that 80 to 90% threshold of immunization within a total population, any total population that we're discussing, very early on. Because what ends up happening is that remaining 50%, and as you recall, I've mentioned, Orange County, our total population, 385,000, give or take, is vaccinated at 50.9%. So the remaining percentage of the population, which is about half, is a conduit for disease transmission. So as that disease propagates from one individual to the other, that disease replicates as each individual becomes a virus manufacturing facility. As they're manufacturing new virus, that virus mutates, and that's where we're seeing these emerging new strains. Whether that strain is Delta, that's the currently prevalent strain that we're seeing, or Lambda, that's sort of on the rise, or other strains that we have not come across just as yet. We are just attempting to either slow down the rate of propagation until we can adequately vaccinate the population, in hopes of eradicating the disease entirely. But if we're unable to do that, we're at least, at minimum, at baseline, are attempting to slow that propagation with other measures such as social distancing, masking, washing hands, so on and so forth.
I know it's on the agenda later, but we're here now. So you were talking about the vaccines, and there's been some new guidelines over the last week or two, state recommending people who have had a vaccine, who are immune compromised, or now they're talking about just any vaccinated person to get a booster 8 months after their last dosage. I'm also hearing that they're recommending that if you had Moderna in your first turn, that they're recommending you take Pfizer because of the different variants within inside the vaccines to do that. But in the beginning, they were saying, well, you had to have match. And I'm also wondering, because I'm seeing that we have fully vaccinated and then partially vaccinated residents, have we developed a system, or can we, to reach out to those people who had only one dose and try and get them to come for that second dose? Are we looking at possibly opening up a larger, the pod like we had at Hatfield Lane again, or that 8th month rotation, and, sort of similar to like,
Absolutely.
it looks like this is going to be something along the lines of what we go through with the flu vaccine.
So you're taking my thunder. I was actually reserving that for the summary, for the update. But we are contemplating, we're actually in the process of setting up pods in Middletown, Newburgh, and Port Jervis, because what we are seeing as far as reported vaccination rates, we're really trying to address that western corridor and a lot of our lower areas of lower vaccination. So Monroe, Middletown, Newburgh, some of the western areas of the county, Port Jervis, so on and so forth. So we absolutely are standing up pods. We're also working in the field. As a matter of fact, right after the meeting, I'm going out to vaccinate a 90-year-old resident in Washingtonville, and I've been doing so along with our staff. So we are vaccinating homebound residents. We are vaccinating out in the field, whether it's organizations that are requesting it right then and there. We're trying to sort of divide and conquer and not stand up a very large pod, because we don't know what the uptake is going to be. In September, we are anticipating having FDA approval for, in the least, the Pfizer vaccine, but hopefully the mRNA vaccine series, so Moderna and Pfizer. As far as recommendations currently, and I do understand that they do keep changing almost daily and hourly, but at this time, the recommendation from ACIPs did come out for individuals that are immunocompromised or immunosuppressed, and they're actually very prescriptive with what types of individuals that includes, whether that's organ transplants, cancer, or immunocompromised. So it's very specific as far as what conditions qualify currently, as we speak today, for the booster shots. And that's simply due to how much antibodies and how much protection the original 2 doses warranted, as we're discussing other, obviously, emerging variants. A lot of this information is accurate and valid as of today, and that's not a testament of vaccine efficacy or safety. That's more of a testament where we are with total vaccination percentages, because as I've mentioned, there may very well be circulating variants right now emerging newly, as newly infected individuals are manufacturing that virus and transmitting it on forward. They're very well may be an emerging variant that that renders vaccines obsolete, that will emerge as vaccine resistant, and that's where we're seeing the nucleotide mutations for other viral strains. Unfortunately, currently that's not the case. We haven't sequenced any that are vaccine resistant, but down the line, a week, 2 weeks, a month, 2 months from now, that very well may be the case. Currently, thankfully, that's not the case. That's why we're still trying to ensure that the majority of our population is vaccinated and protected, because clearly COVID natural infection versus vaccine provides a much higher level of immunity than any prior infection, and a testament to that is the secondary and tertiary infections that we are seeing in residents. So there are a very high number of residents, I could provide the exact numbers at a later time, that are contracting COVID-19 for a second and third time. Again, as their immunity wanes past that 90-day threshold, they're no longer protected sheerly because they don't have any circulating antibodies or they don't have enough circulating antibodies to protect them from disease. As far as boosters, for now, it's the immunocompromised. They are recommending them 28 days past your final dose if it's the mRNA, not for Johnson & Johnson, just mRNA vaccines for Pfizer and Moderna. And they are recommending you stick to the vaccine series that you've originally obtained. I know they're saying cross, and the reason for that is not the safety concern. It's more because it just hasn't been studied and proven in clinical trials as far as what combinations work at what intervals. Because as you recall, Pfizer has a different interval of 21 days rather than Moderna of 28 days, so on and so forth. And you want to ensure that you're administering vaccine at the highest efficacy, at the proper intervals, at the proper dosage. So that's really the reasoning behind not mixing the Pfizer, Moderna, not so much for safety concerns, more because we don't have clinical data. Also, the newest update is the CDC and ACIPs did come out with recommendations for pregnant women because those clinical trials have completed. So there are recommendations for vaccinating for pregnant. Hopefully that kind of covers the general.
Thank you, Doctor. As we move on down, we have the monthly update, as you had just mentioned.
Yes, the highlight.
Right on into that.
Thank you very much. We currently, as I've mentioned, the New York State vaccination website, the New York State COVID vaccine site, reports that we currently have 181,181 residents with completed vaccine series, which only accounts for 47%. However, that is not a complete data set, and we did query the CDC to obtain that value that I originally reported at 50.9%. That's according to the CDC because those numbers include the federal vaccination program, because as I mentioned earlier, if you're a veteran or if you were vaccinated on military bases, you weren't included in the New York State reported numbers. So just for accuracy, kind of housekeeping. As that compares to the rest of New York State as a whole, for the entirety of the New York State population, is vaccinated at 57%. I know we've heard the number 70, other numbers, that's of one vaccine dose in 18 and over. So as far as completed vaccine series in the entirety of our New York State population, that's at 57% currently. In general, the department is very busy with summer activities, such as inspecting children's camps, fairs, festivals, swimming pools, beaches. There are a total of 44 children's camps under permit, 36 day camps, and 8 overnight camps. These are smaller numbers than typical. On any given year predating the pandemic, we typically have around 60 to 80 camps, but some, not surprisingly, have decided not to operate currently. As far as the brief COVID update, because I think we've covered some of the finer talking points, we have issued, as I've mentioned, a public health alert. That was public health alert number 21. That was simply our baseline function of alerting the public to the increased transmission of disease in our community. So individuals are able to take protective measures and are aware of the designation from the CDC changing to a high risk of transmission in Orange County, as well as alerting residents to the fact that the Delta variant is the prevalent variant circulating statewide, nationwide, as well as in Orange County. The county website COVID page continues to have information for the public regarding New York State and federal guidance documents, and those are updated quite frequently, almost daily. We are continuing to recommend that residents go to vaccines.gov. And by entering their zip code, they can look up the closest vaccination location with available vaccine type, as well as hours of operation and other information. based in part on last month's CDC visit and recommendations to improve vaccine confidence, and I think I briefly covered this at the last meeting. We have had the CDC and the New York State Department of Health here. They have helped our Community Health Outreach Division go out all across our community to address vaccine hesitancy and really the reasons why individuals may be hesitant or not want to vaccinate. As a result, and that was the rapid part of the rapid community health assessment, the Division of Epidemiology and Public Health Planning had its first Vaccine Confidence Coalition meeting on August 13th as a result of that CDC visit and that CDC presentation, as well as their recommendations for improving vaccination rates throughout the counties. And this was more of an evidence-based approach to what we can really do and which entities within the county we can collaborate with to improve our vaccination rates. I'm glad to report that well over 100 individuals representing all sorts of different community health organizations, community leaders, so on and so forth, participated in the meeting virtually. We are meeting again in 1 month, and in the meantime, we are forming 4 groups around the areas where we are concentrating our efforts with outreach and health education, predominantly where vaccine rates are lower than the county or the state rates, as well as to address low vaccination rates or disproportionate impact of COVID-19 in those communities. Those areas include Town of Palm Tree, Team West, which includes Port Jervis, Cutterbackville, Huguenot, Sparrowbush, Johnson, Unionville, and Westtown, City of Middletown, and City of Newburgh, and we will be developing consistent messaging, community partnership, capacity building, and a more unified collaborative approach in these areas to get more people hopefully vaccinated. In terms of our homebound populations, as I've mentioned, I have been all across the county vaccinating within homes, within businesses, within organizations, but the nursing division continues to vaccinate the homebound populations who register on our website or are in contact with our office for the aging. And you can go to orangecounty.gov.com, a homebound vaccination, to register any individual that is interested in obtaining vaccines. In general, I think I've mentioned, even as I am delivering the report, our data and our numbers keep changing. Unfortunately, they are not decreasing. Our disease transmission rates are currently increasing. As of today, we have 50,174 cases. We had 132 cases reported just today alone. To date, we had 871 deaths. And as I mentioned, about 50.9 or approximately 51% of our population is vaccinated. Our rolling 10-day average as of 8/11, and this is due to just lag for aggregate data, was 97 cases per day, and that has been a 736% increase since the last report on 7/14, from 11.6 cases per day. Our 7-day average percent positivity rate as of August 11th is 4.1, and that's up from 0.9 on July 14th, and that's the date of our last report. From August 1st to the 11th, the median age is 31 years old compared to 34 years in the month of July. There were 4 deaths reported in July. There has been 1 death reported in August that we are aware of and have the death certificate for. And the median age for July deaths was approximately 67. Excuse me. As of August 13th, CDC reported that 51% of the total population in Orange County is fully vaccinated, and of those 12 years and older, that is approximately 61.1% of Orange County residents that are fully vaccinated. The reason that I typically only report the total vaccination numbers is because it's very important for population health purposes to account for the entirety of the population, because the disease spreads through everyone who resides in Orange County. CDC reported on August 8th that Orange County has high transmission, which was the premise to that public health alert. As of August 11th, CDC calculated our rate per 100,000 as 188.3, which was a 109.5% increase from the previous week. And the CDC uses only PCR positive results to calculate this information. As I reported before, nearly 24% of the currently active cases are pediatric, under the age of 18, and majority of our hospitalizations within the county, and when I say majority, upwards of 90% of all individuals currently hospitalized in Orange County are unvaccinated. So that, in a nutshell, is the report. And I don't know if there is question about this, but we have been receiving a number of inquiries with regards to COVID-19 PCR tests. Those have been grossly misinterpreted in the public and just generally misconstrued. And just as a point of clarification, new guidelines from the U.S. Centers of Disease Control and Prevention withdrawing their request for emergency use authorization for a coronavirus test introduced in February of 2020 do not mean that these polymerase chain reaction PCR tests have failed to differentiate between COVID-19 and influenza. I know there have been a lot of claims to that, but rather the agency is advising the adoption of new tests that can check patients for both, and I have to highlight and underscore, both SARS-CoV-2, which is the virus that causes COVID-19, and influenza viruses, and they can absolutely decipher between the two, just so we're kind of clear on that aspect. So this is not due to the test failing or confusing SARS-CoV-2 with influenza, but in order to essentially facilitate that diagnosis of both viruses and not to administer two tests. So just as a point of clarification, because this has been quite frequently misconstrued. And we can most certainly test for different variants. So as far as that has been a secondary question that has been asked for more frequently than I care to discuss it right now. But just generally, SARS-CoV-2, as we know, is an enveloped, positive sense, single-stranded RNA virus with a 30 kilobase genome with which all viruses accumulate nucleotide mutations over time. I've mentioned that before. As individuals contract and transmit virus, they're manufacturing that virus tends to mutate. So they accumulate those nucleotide mutations over time. These mutations result in the formation of distinct viral lineages. Since its characterization, genomic sequencing of SARS-CoV-2, and this is not new and this is not specific for SARS-CoV-2, but it has been utilized for SARS-CoV-2, has been conducted to identify mutations and any corresponding amino acid substitutions. So when we're seeing the same groupings of mutations, that gives rise to prevalent strains that circulate. They're either highly transmissible or carry a high viral burden. When we're seeing the same substitutions or mutations, we tend to designate that as a strain. So whether we call it flower, ABC, 1, 2, 3, delta, lambda, whatever it's called, it's to account for these random sets of mutations that are similar, that we are seeing via genomic sequencing of viruses. They're conducted to identify mutations and any corresponding amino acid substitutions. Although the emergence of these new variants is expected and most have no impact on viral behavior, so the majority of the transmissions don't really have any impact, even if there are random 1 or 2 substitutions. Unfortunately, some mutations may produce changes in the phenotype of the virus. And the public health risk of known and emerging variants can be broadly characterized into 5 main domains. So this is the reason why we're concerned with different variants of the virus. It can potentially account for increased transmissibility due to increased viral shedding or binding affinity to host cells or stability of the virus. The secondary reason is atypical clinical course, so either increased severity or atypical signs and symptoms. That's what we're seeing right now with increased rates of hospitalizations with certain populations or demographics. The tertiary reason is diagnostic failure, so decreased performance of either some laboratory tests or, as we mentioned, vaccination potential. There could be vaccine resistance, so that's why it's very important to keep track of mutations, and that's why we conduct these tests. These tests are very costly, they're very time-consuming. There are only 5 or 6 labs statewide that are able to conduct these tests. That's why not every single laboratory specimen that's sent out is tested for its genomic sequence. We batch test and we extrapolate that data and apply it to what we believe to be the prevalent strain at the time. Now, also this can account for decreased effectiveness of natural and vaccine-derived immunity, as we mentioned, potentially vaccine resistance, and decreased susceptibility of therapeutics. So I had to mention that because we are receiving just a tremendous volume of calls, inquiries, specifically due to that misinformation.
Thank you. I think we'll have one more question here with legislator Nagustakis.
Thank you. Doctor, thank you very much, as always, for everything that you do.
Thank you.
Just over the last few days, listening to some of the experts on TV and other sources, talking about some of the southern states that have admittedly very, very high levels, but they seem to think that they're potentially peaking and starting to come down in those states at this point, and they could see an end to this over the next month and two. And those same people are saying, well, a lot of these northern states, New England, Midwest area, we're seeing upticks from very low levels, but they don't know what's going to happen at this point. They don't know if it's going to end up being the same situation that they're seeing down the south. Do you have an opinion on that you can give us?
It's very difficult to gauge that because, again, it's changing rather rapidly, and now that we're discussing the prevalence of Delta variant and the higher rates of transmission, we're also contending with Lambda variants and other emerging variants as we speak. In terms of other states, it's very difficult to compare the two because it's essentially comparing apples to oranges. It really does have to do with a lot of the baseline measures that are taking, both protective as well as just clinical and test-wise. If you're not testing, if you're not reporting, if you're not designating certain resources for the actual testing and baseline reporting out of information, it's very difficult to compare the two. Where we're going to be, we are seeing exponential daily increase in positive cases, and these are PCR lab-confirmed cases in Orange County. We can anticipate to see that throughout the fall. Where it's going to peak, it's very difficult to gauge that within the population, and this elusive concept of herd immunity based on prior infection is not something that we're currently seeing because, as I've mentioned, we are seeing reinfections, secondary, tertiary, with the same individuals being infected for a second and third time. So because of those variables, and again, not in absolutes. You may have an individual that can carry that natural immunity from prior natural infection past 6 and 7 and 8 months, as is reported in literature. But majority of the population, that the level of circulating antibodies wanes past 90 days. So gauging that susceptibility is very, again, in absolutes, is very difficult as far as projections, but we can most certainly anticipate an increase throughout the fall and the winter.
Just to conclude, my observation on these southern states, just looking at the data, is I'm assuming a 50% vaccination rate for them. I'm looking at where their occurrence numbers are and how many deaths are occurring. It seems to be almost half as many as what happened the first time around, which would make sense since half the population is vaccinated. So the amount of people dying is half as many. Is that a potential of what would happen here in Orange County if this continues to accelerate?
We may potentially see less deaths. Also, a lot of the clinical parameters that have been implemented in terms of therapies that we have now that we did not have at our disposal early on. The sheer availability of beds, availability of vents, availability of countermeasures are not to be compared with the beginning of the pandemic. And as you've mentioned, a lot of our susceptible and vulnerable older populations, immunocompromised, are vaccinated. Whether fully or not remains to be seen with obvious potential for boosters, but it's a different mortality and hospitalization statistic. But with that, I will again emphasize the earlier point where we are not discussing quality of life post-COVID-19 infection and long-term implications. So as far as literature on complications from natural disease, because unfortunately the discussion really centers around risk of vaccination, which is a risk like anything else, like taking a Tylenol or crossing the street or driving a car. We all have certain levels of acceptable risk to us versus an acceptable risk for our neighbor with anything we do. But typically, unfortunately, these conversations strictly, first of all, are in absolutes, and second of all, they lack the complete conversation, which includes long-term complications, whether that's long COVID, and usually even in kind of short, brief summaries that are given. Again, we're reporting numbers that are positive, test positive. We're not accounting for the population that's asymptomatic, pediatric, that's mildly symptomatic, that may be carriers that may contract and transmit, but they go unaccounted. But also we're not accounting for long-term sequelae of the disease itself and the long-term repercussions. SARS-CoV-2, unlike its other coronavirus relatives, shall we say, there are over 100 coronaviruses that have been known throughout time. SARS, MERS, other ones, and I think we've discussed it in detail before. Unlike the preceding coronaviruses, SARS-CoV-2 reproduces in cells all over the body. So predominantly coronaviruses reproduce in the respiratory tract. They're respiratory type viruses. We are isolating SARS-CoV-2 virus from cardiac tissue, from neuro tissue. So SARS-CoV-2, where it's different, it affects organs throughout the body. So when we're having a discussion that's simply based on mortality, hospitalization, and sort of the acute nature of the disease sequelae, isolation, quarantine, other parameters, we're not accounting for long-term complications. What is colloquially referred to as long COVID at this point, just because it lacks a better clinical terminology. But what we are seeing most certainly reported in clinical and medical literature are long-term consequences of the disease. And those are cardiovascular, those may be reproductive, those may be neurological. And ACE2 receptors, for which SARS-CoV-2 has an affinity for, are located throughout our bodies, including the testes, including kidney, they're really all over. So that's why it's a very incomplete discussion when we're saying safety and efficacy of vaccines that are scrutinized to no end and that are tracked, and post-administration of vaccine, we will be tracking any untoward consequence for years to come. So if a year later you happen to be hospitalized due to a digestive issue, we're still attributing it to potentially a COVID vaccination a year prior. That's not the case with COVID. It may go undetected. So this was the case with myocarditis that was reported, where we don't have a comparable statistics with natural infection and occurrence of myocarditis long-term versus, and it has been reported by the American Pediatrics to be around 1.5 to 3% of 18 and under of all individuals who have contracted COVID present with myocarditis, but it doesn't have a comparable value for vaccine administration. So those are incomplete conversations. It's not just hospitalization versus mortality. It's also quality of life post-COVID. So when individuals are making those decisions and assessing risk for themselves and their loved ones, they have to take into consideration long-term consequence of natural COVID disease, if we are to really have a complete discussion on this. In terms of the epidemiological curve, as you and I both know, University of Minnesota reports the historical pandemic curves, and this seems to be the third one. Typically, this is where it kind of wanes and naturally wanes after the original wave. But due to our extremely low vaccination numbers and not really effective prevention measures, such as the very basic and the most benign being masks or other social distancing, hand washing measures, it's very difficult to gauge where that third curve will pan out.
And if I may add, the world vaccination rates are dramatically lower than what we are here in the United States. So if you can conclude very briefly your opinion that this is not going to be a pandemic, but a lot of people think this is going to be an endemic, that this is going nowhere.
Well, and that's usually the question of where does this end? In terms of, and clearly every medical provider was very hopeful early on when we did have vaccination available that once we reach an adequate percentage of the population, being at least 80 to 90% vaccinated, where we would effectively eradicate the disease from the population. Unfortunately, that hasn't come to fruition, so there may very well be a point, as you've mentioned, where we consider this endemic. We treat this as a flu-like illness, and we report aggregate data versus tracking individual cases for isolation, testing, quarantine, so on and so forth. That very well may be the case, and that again goes to the discussion of acceptable level of risk. Thank you.
Thank you, Commissioner. Appreciate you all the information today.
Thank you very much. I appreciate your time.
Chairman, I'm sorry,
you.
could I just, for the sake of, it's Janet, just for the sake of time, would you be kind enough to email us an update on sexually transmitted diseases?
Yes.
And whatnot throughout the county?
Absolutely.
Thank you so much.
You're very welcome. Thank you. Thanks.
Thank you. All right, next up, we have number 3 on the list, Donna Strecker, Director of Finance for Valley View. Hi, Donna.
Well, good afternoon, everyone.
Thanks.
So,
The financials.
yeah, financials. So the results that you're reviewing, these are the results as of July 2021. There's been no change to the IGT funding since the last publication, 1.5 million. We do not have any entries yet for the appropriated surplus that usually books at year end. Emergency disaster, we received a small amount of money, 22,000. Other revenues are coming in at 18 million. On the personal service side, 12,558 has been expensed so far. On the equipment side, we've expensed 51,694. Contractually, we have 3.5 million earmarked for expenditure. Through July 31st, we've expensed 4,722. Employee benefits are coming in at 10 million, and we have a small amount of serial bond interest debt at 87,162. If you turn to the next document, you'll see an analysis of bill days by payer source. All the way to, on the top, we have 2021 performance. On the bottom, we have 2020 performance. If you go all the way over to the right, in July, our census totaled 80.68. Our year-to-date census, the average for the 7 months being reported is 74.99. The Medicaid population we serve represents 77.23%. The Medicaid HMO is 3.52, and Medicare at 11.69. To the next document, you'll see the historical occupancy for the facility. 80.68 for July and 74.99 is the average.
And what does that represent on number of patients?
Pardon?
80%, how many patients do you have now?
As of today,
I saw that somewhere, but I don't have it.
our occupancy today is around 80%. We have 80.27 today, so we have 289 beds that are filled, and we have 71 that are unoccupied.
Occupied, okay. Does anybody have any questions about the financials? Now, I know that unfortunately, Mr. Ledoux was unable to join us today. Do you have a copy of his report, or do you?
I do.
Do you want to just read that or give us some highlights
Sure,
from it? And
Sure,
then,
I can do that. So we talked about the fact that our occupancy was at the 80.27%. Our occupancy has been growing. 71 unoccupied beds, 289 are filled. We currently have 1 resident with COVID. We have 3 staff members that are out due to COVID positive or due to COVID contact precautions. 92% of our residents have been vaccinated. 62% of our staff population have been vaccinated. That leaves 166 right now that have not been vaccinated. We continually to regularly offer vaccines. Yesterday, New York Governor Cuomo announced a new vaccine mandate for healthcare workers in hospitals and long-term care in New York State. The new mandate will require healthcare workers to be vaccinated against COVID-19 by 9/27/21. The facility is waiting further advisement from the New York State Department of Health at this time.
That'll be a huge help to you, right? Get everybody, the other percent vaccinated.
Pardon?
So that will be good to have that other, they're mandated to get
Yes.
vaccinated. It's been a question going back and forth for the year and a half, or since we got the vaccines for this year. And, hopefully, do you anticipate any kind of loss? I know staffing's hard right now, but do you think people are going to
It is a
decide not to get it?
possibility, yes. It definitely is a possibility. I mean, you have a certain percentage of people that, may be reaching retirement age that may just elect for personal reasons that they do not want to take the vaccine. You also have other people that have, they may be considering pregnancy or are pregnant, and for personal reasons, they may decide that they don't want to take that. So we're keeping a close eye on that. Since it's so new, we don't have a lot of feedback at this point. I did check with the director of nursing today just to see if she had any information yet from the staff.
Thank you.
COVID staff testing has changed. Staffing that have COVID vaccines no longer need to get tested regularly, except during an outbreak of COVID-positive resident or staff. And staff that aren't vaccinated still get tested. He has twice per month. I think it's twice per week. Valley View CHA currently has 14 patients, and each patient typically is receiving 4 rehab visits per week in the community by a physical therapist and 2 occupational therapists. These visits occur after the initial visit assessment is completed by the RN. Valley View, like other healthcare facilities, is continuing to struggle to hire new staff, RNs, LPNs, and CNAs. Providers across the continuum are facing extraordinary workforce challenges right now. Recruiting for RNs, LPNs, and CNAs has become incredibly difficult, not only for Valley View, but for all healthcare facilities. Lawrence knows of 2 facilities right now, one in the local Orange County that has paused admissions due to staffing. And Valley View has reached that point as well. Effective August 16th, we are going to pause new admissions into the nursing home, and we are going to maintain our census at about 295 to 300 beds. As a result, one of his major concerns is that he will have to limit access to Orange County residents that are seeking care at Valley View. At this time, he has to pause due to the number of vacancies that we have and our attempts to recruit. And as our census is starting to climb, we have to pause. We want to make sure that we have adequate staff on hand to continue our mission of providing extraordinary care for the residents we serve.
And I guess there's no way to anticipate how long that pause will be.
We don't. We collectively met as a team on Monday morning, and we met with the director of nursing, and what we decided was that we have 11 units that we would consolidate, our care by closing one of those units and filling up the other units. We had approximately 22 residents on the unit that we have decided to kind of close for now, and we've moved them out into the other 10 units. That will help a little bit with the staffing, take some pressure off of having to staff 11 units.
And as people get discharged, will you be
We'll be
filling those
continuing-
beds? Or are you going to wait for the pause?
We're gonna pause here for a little bit. It's gonna take a little bit. We have to notify DOH that we're consolidating care by closing one unit. We've had to contact the family members, so this is all a work in progress right now. We also have 5 residents, I believe, that are at the hospital right now that will be coming back to the facilities. So we'll be pretty much reevaluating on a daily basis.
Okay, thanks.
You're welcome. Lawrence had emailed everyone a report from Leading Age. The report outlines how the population 65 plus and 85 in New York will continue to increase at least to 2030. It also outlines the current and growing need for CNAs, LPNs, and RNs to provide care for the aging population. Leading Age is outlining some strategy, the information he has sent to all New York senators and New York assemblymen that represent Orange County. I hope you will support Valley View, he writes, and our staff by promoting the strategies outlined in the report. Valley View participated in Orange County Virtual Job Fair this week. There were 10 attendees looking for jobs, and none were in the nursing healthcare field. We have BOCES students returning to do clinical rotations in the facility in September. We are also going to begin advertising on electronic billboards on Route 17, and we are developing a sign-on and referral bonus as well.
Okay, thank you.
You're welcome.
Legislators, any questions? Nope, not seeing any. Don, I want to thank you very much. I know you had to wait a while, but I appreciate
okay.
the information, and keep us posted
We will.
as far as the pause and everything else. Thank you. All right, that clears the agenda. If I could have a motion to adjourn? Lori? And I'll second. All in favor? Aye. Meeting adjourned.